All right, so schizophrenia spectrum disorders. So it affects about 1% of adults, which you might think is kind of a small number. However, it is a very debilitating illness. It's probably one of the most debilitating of the mental illnesses in terms of people being really able to live their lives. So characterized by psychosis. So if somebody is psychotic, that means that they have trouble with their thinking, their perceptions, auditory, visual, and others, and reality testing. So reality testing means like that they can tell the difference between what's real and what's not real. So do you think in the simulations that patients were able to tell the difference between what was real and what was not real? No, absolutely not. The pizza was like bubbling; it was poison. The coffee was bubbling. The bottle in the pharmacy said poison. So they don't have reality testing. 75% develop really gradually. So most people, it's kind of the onset is gradual. It's not a sudden boom. You wake up one day and you're psychotic. Usually late teens to early 20s is the unfortunate age of onset. Very rare to have childhood onset and very rare to have adult onset. I did see a patient once, though, that did have adult onset. It was really distressing because she was a mom. She had like 6 kids, and her kids were mostly teenagers, and some were even out of the house already. So I think she might have been in her late 40s, early 50s. So she had, raised all these children, and she was a nurse. She was a high-functioning person in the community, and then she started developing terrible delusions and hallucinations. And her delusions and her really bad intrusive thoughts dealt with killing people. Like the voices would tell her to kill her family, but she had enough insight to know that that's when she needed to come into the hospital. So she never actually did anything to hurt her family members, but she did have some very, very distressing symptoms. And this started late in life because she was really pretty functional up to that point, but that's really quite rare. It's usually late teens, early 20s. So the symptoms that we're looking for are delusions. So it's good to know the difference between delusions and hallucinations. Does anybody know offhand what that is? Because I even hear staff on 1K mixing those two terms up every now and then and saying them erroneously. So what is a delusion? Anybody know?
That's when you think, like if you think you're God or if you think
Yes.
you can talk to dead people or
Yes.
hallucinations, you
Yes.
are seeing things.
Right. So delusion is an idea. It's a thought. So, and it's false. It is not based in reality, and it's fixed. You cannot talk them out of it. They absolutely believe it. You cannot talk them out of it. And then the hallucination is a sensory experience. So it's either auditory, visual, tactile, gustatory, what's the last one? Olfactory. So it really deals with all of our senses. They have disorganized speech. So it's really difficult to talk to somebody and carry on a conversation when somebody has schizophrenia, because sometimes they might speak in rhymes. Their speech is disorganized to the point where you can't even figure out a sentence. So they do have problems with their speech. Grossly disorganized behavior, or they could be catatonic. So have you heard the word catatonic before? I think we talked about that a little bit with depression. Didn't we mention that? So that is when somebody just absolutely is not responding to you. Okay, their eyes are closed usually. They don't talk to you. They don't look at you. They may or may not be cooperative with nursing care, such as like if you try to like put something up to their mouth to have them drink or eat. You might have to feed them. Put something up to their mouth to help them to drink fluids. They may or may not be resistive. They might clench their teeth, or they might just accept what you're doing for them. A student once, a few years ago, had the opportunity to straight cath a patient who was catatonic during clinical. So that was really interesting, and she cooperated, thank goodness. Because if you think about it, really she could have clamped her legs shut, and that would have been extremely difficult. But she wasn't getting up to the bathroom. We really had to. I think she was accepting sips of fluid, whatever, but we had to cath her. And I was so impressed because the student talked to her the whole time. She talked her through the entire procedure, even though the patient kept her eyes closed and looked like she wasn't even with us. The next week, the patient was better. And a couple students were in there, and myself were, in there doing the straight cath. And the students were talking to the patient, and they were telling her, it was Halloween time, and they were telling her a story about pumpkins or something. Well, that next, and look, seriously, no response whatsoever. The next week, the patient was better, and she remembered the story about the pumpkins that the students were telling. So they're in there. They're just not responding. But they're so psychotic that it prevents them from interacting with the world. So negative symptoms are things that usually have to deal with diminished emotional expression or avolition. Does anybody have an idea what avolition means? I think we mentioned that maybe in depression too. So some of these symptoms are similar to depression, the negative symptoms. You know what avolition means? Volition is like get up and go to get yourself someplace, and to accomplish things that you need to accomplish in your daily life. So if you guys had avolition, nobody'd be here. I'd be sitting here talking to myself, right? You got up, you got dressed, you got showered, you got yourself here, you're ready to go. That's volition. So if you have avolition, you just don't have any get up and go. There's nothing that's stimulating you to just have ordinary day-to-day behaviors. They usually have functional impairment of some kind, so maybe an inability to relate to people, an inability to hold down a job, just inability to accomplish their daily ADLs. And the disturbance has to be for at least 6 months, because you can have there's something called a brief psychotic episode. So if something stressful happens, people can maybe be psychotic for a brief period of time. It doesn't mean they're developing schizophrenia. It probably will resolve with treatment, of course. And the other thing is that you could have a temporary disturbance that could be drug-related. So we saw somebody in clinical this week. It wasn't your patient, was it, Katie? No, it was somebody else's patient who had been using meth. And he was very psychotic when he came in. Eyes darting around. In fact, the day that the student took care of him, he was better. But the day before, the nurse was saying that his eyes were darting around, and he was talking about all these really strange delusional ideas, and that was meth related. So and that's going to be short lived. So it's got to be at least for 6 month time period in order to be diagnosed. So a little bit of a case study. So Eric M, 18, has always been a good student. However, okay. In his second semester of college, he begins for the first time in his life to have trouble concentrating. When his family doesn't hear from Eric, they contact the school only to discover that his roommate says Eric is talking weird. Asking what he means, the roommate says, well, he says stuff that doesn't connect, doesn't make any sense. I asked him if he was high or something, but he said no, and I believed him. On further investigation, Eric's professors say he's been missing class after starting out so well. So Eric's roommate says his speech doesn't connect, it doesn't make any sense. He sort of gets derailed. So which of the following symptoms is he displaying? Avolitional speech, delusional, disorganized, or diminished emotional expression. Which do you think that would be? Yeah, disorganized speech. I don't think there's any such thing as avolitional speech. I didn't make this up, by the way. Okay, so epidemiology, childhood onset, 1 in 40,000 children, so really very rare. And schizophrenia knows no bounds. Race, social status, culture. It doesn't matter if you're rich, poor, come from any part of the world. Everyone experiences, all cultures, all parts of the world experience schizophrenia. I'm getting really dry. It's more frequently diagnosed among males and in urban areas. So we have lots of comorbidities. And when I show you the other little video clip about a girl named Heather, you'll notice some of these comorbidities. So substance abuse disorders, for sure. Many times people use illicit drugs or alcohol in order to self-medicate. They may stop their medications and then they're using drugs and alcohol to feel better. But of course, it doesn't make them feel better. and nicotine dependence. So in the old days, people could bring their tins of tobacco and roll their own. So, yes, we actually allowed that. I'm not sure why, but we did. So they wouldn't even want a filter. That's how dependent on nicotine that people with schizophrenia were. And you can always tell when they've got the staining, their nails are stained, their fingers are stained. There is something, I read an article a long time ago, there is something to nicotine that actually helps the person with schizophrenia, like, to focus. Like, it all, like, holds everything, holds your thoughts all together and helps them to kind of focus a little bit. But of course, that's not a good thing. We don't want people using nicotine. But that's probably why it's some reaction in the brain that seems to help them to focus a little bit better. Anxiety, depression, and suicide are huge comorbidities. And when we go over the negative symptoms of schizophrenia, you're going to see that most of them really sound like they're kind of very similar to what we talked about in depression. And suicide is a huge risk because people that have command hallucinations will follow whatever the voices tell them to do. Okay? And many times if the voice says, kill yourself, they are going to kill themselves based on what the voice tells them to do. There was a patient who jumped off of a roof because the voice was telling them to do that. So we really have to assess those hallucinations very carefully. So suicide is a huge risk factor. And some people just get to the point where they really get tired of the struggle, the constant struggle, the hearing voices, the negativity. You can only hear voices so long that say you're worthless, and that it really does erode their self-esteem. Physical health or illness is a comorbidity. Why do you think that would be? Do you think a person with schizophrenia takes really good physical care of themselves? Right? Are they going to the doctor for regular checkups and screenings and stuff like that? More than likely not. Are they doing their ADLs? How about just general cleanliness? Have you observed anything? And I know 3 of you had been in Lifespan, and then Katie, I don't know if you had anybody this week that had any of these symptoms. But what else do we observe about people with their ADLs and their ability to take care of themselves? What else do we observe about that?
We don't show.
Okay.
Yeah, their teeth are usually rotten.
Yes. Teeth are usually rotten. Don't shower, so skin issues they can have. That one patient now on the unit we didn't take care of him, but he's got bed bug bites all over, so ADLs are really poor. Teeth rotting out of their mouth or loss of teeth. Like, I've seen people in their 30s and 40s, no teeth left, or just all black, rotting out of their mouth. They're not brushing their teeth, they're not going to the dentist. And this one young guy who lost his teeth in his 20s was drinking like 24 Mountain Dews a day and not going to the dentist. So that's an awful lot of sugar. So lots of comorbidities. Sometimes they develop diabetes as a result of sometimes the medications can cause weight gain and metabolic syndrome. So then they're developing diabetes on top of everything. So can you imagine having schizophrenia and trying to manage diabetes? Right? Testing their blood sugars, eating a healthy diet, managing all of that. So lots of physical health or illness comorbidities. Polydipsia is an interesting comorbidity. What is polydipsia? You guys know? Okay. So increased thirst, but they're drinking like lots and lots of fluids, usually water. So what happens when you drink too much water? Yes. So that's the polyuria part. So polydipsia and polyuria kind of go hand in hand. But what is the med-surg? Think med-surg for a minute. Think the med-surg consequences of having drinking like too much water. Yes, electrolyte imbalance. So that's a huge risk factor. Now they used to have water fountains or bubblers, as you guys probably call them, on the unit, but they got rid of them, partly for that reason, because most of the time they would just shut it off. Sometimes they'd have to lock somebody's bathroom to keep them from drinking out of the toilet or drinking water out of their sink because of the polydipsia, because of that excess, and you're going to get water intoxication which is very serious. So that can be just like a standalone effect of schizophrenia, or it could also be a side effect. If they happen to be on lithium for a mood disorder in addition to their schizophrenia, sometimes that's a side effect of lithium also. Speaking of polydipsia, I need more fluids. Okay. So, genetics, of course, very strong genetic predisposition. So, I think I told you about my friend who's one of 5 children, the oldest and the youngest. She's the middle child. The oldest and youngest both developed schizophrenia, and very strong family history, very strong. And mostly on the mom's side of the family. So genetic, huge genetic predisposition. There's lots of other neurochemical dopamine theories, brain structure abnormalities. I believe the ventricles are enlarged in people that have schizophrenia. So it is a brain-based disease. There are prenatal stressors, other different environmental factors that we think have an impact. So prenatal stressors, especially an infection. Okay, so if the mom has an infection during her pregnancy, psychological stressors and environmental stressors aren't enough to cause schizophrenia, but they certainly can bring it on in somebody that's genetically susceptible. So just having stress in and of itself isn't going to make somebody develop schizophrenia. But if you take like the typical scenario, like the case study, the person who goes off to college for the first time. So, yeah, great, it's an exciting time of life, but it's stressful too because you don't have your parents there anymore. You're kind of on your own. You're working very hard as a college student. You may be away from your friends and usual friends that you are, have hung around with. So you've got to kind of make all new friends. So it's a really huge transition point. And so that is actually a very big stressor that has brought on schizophrenia. And I know somebody personally that went to my high school that experienced that. And she was the most beautiful girl and very popular, really good student. Just looked like she was going to go away to school and just, tackle the world. And she went to college and started kind of falling apart. Started having being a little bit suspicious of people and not being able to concentrate, kind of like the scenario in the little case study in this PowerPoint. Not doing well in school all of a sudden, and then she developed schizophrenia. So there must have been, I don't know the family well enough, but there must have been a family history of that. And then in addition to that, the stress of going away. Prognosis, most of the time, I have heard a few people tell me that they know people that actually had schizophrenia and now they're cured. They don't have it anymore. I have never met a person that has schizophrenia that is cured, ever.
That's just, I wanted to ask, I wonder if there would be a good time to ask this. So
Sure.
I had a student who was diagnosed with schizophrenia, and
Okay.
she actually had to withdraw from school. And her
Okay.
doctor, even who I respect a lot, she was seeing a child psychiatrist
Mhm.
involved in the right care,
Mm-hmm.
wrote for homebound instruction, so was really
Wow.
in believing that it was significant. And then that probably happened for 3/4 of the school year.
Okay.
And then unfortunately the student was involved in a really tragic accident. She was traveling in a
Oh, wow.
car and they were hit by another vehicle.
Okay.
Someone was killed in the car. She was paralyzed.
Oh,
in the
my
accident.
gosh. Wow.
But when she was able to return to school,
Uh-huh.
her schizophrenia was gone. Well, not gone. What the child psychiatrist explained to me is that one trauma superseded the other in her brain. So
Uh-huh.
at least for the time being, her
Wow.
brain wasn't expressing the schizophrenia. It was
Huh.
incredibly interesting to me. We had
Wow.
releases on file,
Wow.
so I was
That
able
is
to
interesting.
talk to the child psychiatrist. I mean, I
Okay.
don't know if you'd ever take care of another person like that.
Right,
That would
right.
happen to because it was such a traumatic accident.
Wow.
But I found that, I said, explain that to me. Where did it go?
Uh-huh,
Did it?
right,
She
right.
was hearing voices. She was medicated for schizophrenia. She couldn't come to school.
Oh, my gosh.
And then
Wow.
it was But the doctor, and then that made sense to my brain, that it wasn't that it was gone.
Right,
the doctor
right.
said that it could come back.
Okay.
It was just that
Okay.
her body was dealing with
The other, yeah.
trauma.
Yeah.
They called it like a trauma.
So the other trauma was on the forefront.
Superseding it.
Yeah, I have never heard of that. It's really interesting. My other thought that I would have is that sometimes people get misdiagnosed.
Yeah.
Okay? Because there is a lot of crossover between bipolar and schizophrenia. Many times people get misdiagnosed. So therefore, it's possible
Right. We had
that it was
when
not a
her
correct
initial
diagnosis.
Came because she really wasn't expressing schizophrenia symptoms at school.
Uh-huh.
It was very confusing to me
Huh.
how it was so impactful in her home environment, but we actually
Wow.
it appeared as though we weren't seeing any of it at school. So
Okay.
I had some real deep conversations, but that child psychiatrist
Huh.
couldn't believe
Oh.
that she was schizophrenic.
Very interesting.
Horribly. Yes, and was reporting to her mother that she was hearing voices. They were telling her
Mhm.
negative things. I
Mhm.
saw the AD. I guess there was a little bit of the ADL involvement, but she's a child too, so someone was having to take care of that for her.
Yeah. Yep.
But I did worry
Yeah.
about misdiagnosis, and
Yeah.
kind of actually bluntly said that.
That
to
would
the-
be in the back of my mind.
Uh-huh.
That would be.
It was a very interesting.
Yeah, definitely. So most people that have schizophrenia, it's a lifelong condition. It can be managed, and if, especially if they take medications. However, a lot of times we do struggle with people that they don't have any insight into their illness. They do not see a reason to take their medications, or they just can't get it together to get their like the kind of the scenario where the person runs out of his meds, goes to the pharmacy, things are kind of disorganized. And they just can't follow through with things. That's part of their cognitive issues. So if if they have a supportive, the other thing about the last part of that little scenario, the little video clip too, was that if you have a supportive person in your life, how helpful that is. So somebody who came in, opened up the blinds, presented some reality, some support, like you've got to take your medication, we're going to eat, just if you have that person in your life, much better prognosis than people who are homeless or they're living in an apartment all by themselves and they start to get paranoid, they withdraw, they can't manage, and they end up back into the hospital many times. And that's kind of a scenario we saw with a patient this week too. So Eric's parents arrive on campus. He agrees to meet with them and a campus counselor. He's anxious. He's expressing sorrow that his grades are suffering, says his concentration just isn't there. He says that he feels something weird is happening to me and describes frequent distressing thoughts. He admits to feeling suspicious of everyone he passes. So Eric's parents and the counselor both notice what the roommate has described about Eric's speech. So he agrees to see a psychiatrist. And the initial assessment and history indicate he's only been experiencing mild changes in his thinking and mood for about a month, ever since returning from winter holiday. The examiner confirms his speech is sometimes disorganized, ability to concentrate and study diminished from his previous long-standing as a strong student. So the assessments that we're going to be making then. So that general assessment is the positive, negative, cognitive, and affective symptoms. So we're going to be kind of looking at all of those. Let's think about the phases of schizophrenia, the prodromal. So do you know what prodromal means? Just in thinking about any type of illness. What's the prodromal phase of an illness? Yes, before symptoms are like completely there, right? So it's kind of the things that are leading up to. So I have a good example. It's myself. Monday, I just felt like a little maybe scratchy throat, a little tired, like a little more tired than usual, but nothing really, pronounced or anything. Tuesday and Wednesday, I kind of got through clinical, but like by Wednesday, I was really tired and started to get a little more scratchy throat, a little more runny nose. And then Thursday, boom, it hit me. It was like, wow, I'm really sick. So you kind of, you start out and you're not quite sure what's going on, nothing major. It's just some subtle things, and all of a sudden then you have the acute illness. So it's those mild things, a little bit of suspiciousness, a little bit of difficulty concentrating, maybe socially withdrawing from other people. That's kind of what you usually see in that prodromal phase. It can look a lot like depression. Okay, so again, hard to diagnose at first. Acute phase is that psychosis, it's there. They are psychotic. They're hallucinating. They're having delusions. And the symptoms are so pronounced that you really can't miss them. In the stabilization phase, you've got them on medication. We're assessing that their symptoms are diminishing. We're looking for more clear thought processes. We're looking for the absence of delusions and hallucinations, and hopefully movement towards their previous level of functioning. But if they've developed full-blown schizophrenia, their level of functioning may not be way back to what it was before. So the maintenance or residual phase is a new baseline is established. So they may not get back to their old baseline, but they're going to be at a new baseline. So those positive symptoms then, the alterations in reality testing, so delusions are those false fixed beliefs. They have alterations in their speech. Concrete thinking, so that's that inability to think abstractly. So if you ask somebody, how did you get to the hospital? What do you think they might say if they are a concrete thinker? Yeah, in a car. I got to the hospital in a car. What did you really mean by that question? Did you really want to know how they were transported to the hospital, or do you really want to know what circumstances, what symptoms, right? So they're going to answer you very, very concretely. So that has implications for your communication with a person with schizophrenia, because if you say something to them like, I'm going to take your blood pressure, they may think you're going to take their blood pressure right out of their body. Okay? So you have to kind of say, I'm going to check your blood pressure. So take your blood pressure might be something that may make them fearful, because they're very, very concrete. So they have associative looseness, so they might have word salad. That's the most extreme form, and honestly, I've only seen that a couple of times in my almost 38 years as a nurse. But basically, it's like if you took a salad bowl and a bunch of words and you just mixed them all up, and then pulled them out randomly, it would be just that. It's just very random words that are not connected whatsoever. They're just really meaningless to whoever's listening. Clang associations, I think we talked about that with bipolar, sometimes people that are manic. Clang, so they choose words based on rhyming rather than meaning. Neologisms are interesting. That is a word that the person makes up. They totally make it up, and it has no meaning for anybody except for them. And in the little video clip I'm going to show you on Heather pretty soon, I think if you listen carefully, her speech is garbled, but if you listen carefully, you might pick up a neologism that she has. And then echolalia is pathological repetition of another's words. So, in other words, if I say, how are you today, they're just going to say, how are you today? They're not going to answer my question. They're just going to repeat back what I have said to them. Other abnormal speech patterns are being circumstantial. So that just means that if you ask somebody what time it is, they tell you how the clock was built. They give you all kinds of extraneous detail that is kind of meaningless. They eventually get to their point, though. Being tangential means they start out talking about something and they get derailed on something else, and then they just never get back to what they were talking about. So again, hard to follow. Cognitive retardation is slowed thought processes, so sometimes they sit and they stare at you, they don't respond, you're kind of sitting there hoping to have a conversation, and it's not happening. Okay? They're very slow, they may give you one-word responses. They may have pressured speech, similar to people that have mania. They might have a flight of ideas where their thoughts are just flying out one after another, and again, hard to connect and know what they're talking about. They might have symbolic speech, so they might speak in symbols that are, again, meaningful to them. I guess an example of that one would be, I had a patient that had schizophrenia that he really wasn't able to tell us like how he felt on a particular day, but he would go to the newspaper and he would look in the comic strips, and he would find a comic strip that matched like his mood for the day or his thoughts for the day. So he'd always bring us that comic strip every day, and that was kind of his way, I think, of symbolizing what was going on with him that day, how he felt. So they also, oops, I think I went a little too quick here. Here. Okay. They have thought blocking, so they talk about something, they stop, they can't get back on track. You know, we all do that once in a while, right? You sort of start talking about something else and you forget what you're talking about. Anybody else have that, or am I old? Oh yeah, everybody has that. Okay, good. But this is really extreme. It's so extreme. They cannot, even if you cue them and say, oh, well, you were just telling me about, it's gone. Thought insertion means that they think people can put thoughts into their head, and then thought deletion or withdrawal means people can suck thoughts right out of their head. Take them right out. Magical thinking, if I close the blinds, the sun will stop shining. Okay, that's an example of that. They might have that. And then just general paranoia where they feel that people are out to get them, people are out to kill them. They're suspicious of the motives of other people. All right, so during the assessment, Eric has trouble staying on topic, zipping rapidly from one thought to the next, making it hard to follow what he's trying to say. And so which of these is he exhibiting? Yes, C, flight of ideas. Yep, very good. All right, before we get into this, I think I'm going to show you another little video. Okay, so we're talking about alterations in perception. So again, they can also have that depersonalization and maybe derealization, so that floating feeling which I'm still having. Hallucinations, 5 are usually typical, but I would say auditory and visual are most common with schizophrenia, probably auditory most common, visual second most common. Olfactory, gustatory, and tactile I have seen, so smell, taste, and touch. Usually olfactory and gustatory they're very negative. There was a patient who could taste feces in their mouth, so they were spitting constantly. If you smell something, it's usually something bad. It's not like roses. You're going to be smelling something burning or, just something obnoxious. So they're usually very negative. But those are mostly, olfactory and gustatory, are mostly associated with some kind of an organic problem. So something is really going on with the brain. So it could be any kind of assault to the brain or maybe some other organic neurologic problem going on. Kind of rare to see those just with schizophrenia. But I think the guy that was spitting because he tasted feces, I do believe he had schizophrenia. Tactile, we mostly see that in people that are going through withdrawal. So when they're going through withdrawal, they feel like bugs crawling on them. More typical when you're doing a CIWA assessing for withdrawal. So, so that's an experience that is completely manufactured by their brain. So there is no basis in reality for any of those. Illusions, though, is different. That is when there is actually something there, but you perceive it to be different. So let's see. My example always was, because we used to have the screen, that you pull down, and there was always a cord hanging, and I would always say there's really a cord there, but it's somebody looks at that and sees a snake. Okay, so it's just you see something as different from what it really is. All right, alterations in behavior. So being catatonic, having motor retardation, slowing. Sometimes the motor retardation is so bad, they're in bed all day. You hardly even see them. They are just sacked out in bed. We do see that a lot with depression also. Or they could be agitated. What do you think is the biggest agitated behavior that we will see in an inpatient unit? Any idea? And that doesn't mean aggressive. Okay, agitation doesn't mean aggressive. So, the three of you that have been on mental health before, what did you notice a lot of patients doing? Fidgety. No, fidgety, but pacing? Did somebody say pacing? Yes, pacing. That is huge. You see people pace all the time, especially that have schizophrenia. All the time. Okay, so that is a huge thing that we're going to see with motor agitation. They might have stereotyped behaviors, so there might be some patients that might, they might be walking along and throw a punch or do something else, some other type of behavior that might be related to something else, or they might even be pretending going along and going like this, like they were painting something. So they could have some behaviors like that. Waxy flexibility, I'm going to show you a little video clip in a minute about that one. It's hard to explain, but I guess the biggest thing is if somebody is catatonic and you want to move them, because say if they've been in this position forever, okay, that's what, if you're catatonic, sometimes you're posturing and you're like this. And then waxy flexibility means I'm going to come along and I'm going to move their hand down here, and it's going to stay there. Wherever I move it, it's going to stay. If I move it back up here, it's going to stay there. Okay, that's what waxy flexibility is. So again, if people are having these symptoms, they're pretty psychotic. Echopraxia, okay, we talked about echolalia, so that's when they repeat. If you say, how are you today, they're going to answer, how are you today? Echopraxia is they are going to mimic your behavior. So if you reach down and, scratch your leg, they're going to reach down and scratch their leg. So they're going to mimic your behavior. Negativism is that aspect of them doing the exact opposite of what you want them to do. So if you want them to go on the north wing and stay on the north wing, they're going to try to get off of there as often as they can. They'll do the exact opposite of what you ask them to do. They might have impaired impulse control. They just don't have control of their behavior, and they can get into any number of difficult behaviors because of that. Again, the gesturing or posturing. So posturing, people can actually hold a pose for hours. Literally for hours. They can be like, me, like statues, that game you play when you were kids. Do you guys do that? Mm-hmm. Okay. Well, anyways, it's a game we played when we were kids, statues. So you're kind of, you freeze wherever you are, and you could literally stay there for hours. So do you think that would have an impact on any of your, bodily systems? If you're kind of in a pose same pose for hours. Mm-hmm. Oh, okay, so you might be incontinent. Okay, yeah, it's possible. Yeah, you're going to have some musculoskeletal issues. Skin integrity sometimes, because sometimes their posturing might be in bed, and they're just not moving. They're staying in the same position, so yes, they're going to have skin integrity issues. Okay, great. Boundary impairment. They don't know where they end and you begin. So sometimes they might come up really close to you because they don't have any sense of that you and they are two separate people. Okay? So that's also going to impact the way that they communicate with you.